بسم الله الرحمن الرحيم. TB and anti-TNF alpha treatment. Anti-tumor necrosis factor alpha, TNF alpha agents are approved for the treatment of rheumatoid arthritis, Crohn's disease, psoriatic arthropathy, ankylosing spondylitis. Anti-tumor necrosis factor agents include etanercept, adalimumab, infliximab, Glyomumab, and Cerulizumab. These drugs cause profound immune suppression, and patients treated with them have an increased risk of infections, including TB. Approximately 0.6% of patients started on these agents will develop TB, with no apparent difference between agents. Overall, there is an average 3.5-fold increased risk developing TB with anti-TNF alpha therapy. All patients due to start anti-TNF alpha antibody treatment should be screened for active and latent TB. All patients should have a clinical examination with history of previous TB treatment and exposure carefully documented. All should have a chest X-ray and tuberculin test or EGRA. The EGRA is less sensitive in those taking concomitant prednisolone and or disease-modifying drugs such as adatrioprine. Both those with an abnormal chest X-ray consistent with previous TB or those have a history of extrapulmonary TB who have received adequate treatment as assessed by an expert can start anti-TNF alpha therapy but need monitoring every 3 months with a chest X-ray and symptom assessment. The onset of any new respiratory symptoms, especially within 3 months of starting anti-TNF alpha therapy, should be investigated promptly. Both those with an abnormal chest X-ray consistent with previous TB or those who have a prior history of extrapulmonary TB who have not had adequate treatment need to have active TB excluded by appropriate investigations. They should receive chemoprophylaxis before anti-TNF alpha therapy commences, assuming active disease is not identified. If there is clinical concern because of the delay in starting anti-TNF alpha treatment, a shorter course of chemoprophylaxis can be given, but this may be more toxic. Any TB diagnosed pulmonary or extrapulmonary should be treated with standard chemotherapy. If active TB is present, patients should receive a minimum of 2 months anti-TB chemotherapy before starting anti-TNF alpha therapy. If the chest X-ray is normal, the tuberculin test or EGRA may be helpful if the patient is not on immunosuppressants. The skin test must be interpreted knowing the BCG history. A tuberculin skin test is unhelpful if the patient is on immunosuppressants. In this situation, an individual assessment should be made. If the risk of drug-induced hepatitis is less than annual risk of developing TB, chemoprophylaxis should be given. However, if the risk of hepatitis is greater, the patient should be monitored regularly and any suggestive symptoms investigated promptly. No chemoprophylaxis regimen is 100% effective. The protective efficacy is reported at 60% for 6H and 50% for 3HR. In those without previous BCG, Mantox 1 in 1000 0 to 5 millimeter is negative, and the Mantox in 100,000 more than 6 millimeter is positive and should lead to a risk assessment. In those with prior BCG, Mantox 1 in 1000 0 to 14 millimeter is negative, and the Mantox 1 in 1000 more than 15 millimeter may represent either latent infection or BCG effect and therefore needs further investigation. In general, all Black African patients aged more than 15 years and all South Asian born outside the United Kingdom should be considered for chemoprophylaxis with 6 months isoniazid. If a patient develops TB while on anti-TNF alpha therapy, treat with the full standard course of anti-TB chemotherapy. The anti-TNF alpha can be continued if indicated. Close liaison between the prescriber of the TNF alpha antibody treatment and TB specialists is needed.